Welcome to the Explainer. Today, we're taking some pretty dense clinical data and transforming it into a clear, fascinating journey through the mechanics of 8 major sexually transmitted infections. If you've ever found clinical pathology, well, a bit overwhelming, you are definitely in the right place. We're going to break down exactly how these pathogens operate, how they manage to evade detection, and, most importantly, how modern medicine fights back. Okay, here's our clinical roadmap for today. We'll start with the silent infections, move on to the viral instigators, and then tackle complex multi-stage threats. After that, we'll dive into HIV as the immune hijacker, and finally, wrap things up with screening and prevention. All right, let's jump right into part 1, the silent infections. Now, the silent mnemonic is literally a game changer for remembering how chlamydia works. It's a gram-negative bacterium. And get this, for a lot of patients, symptoms are completely absent. But they are still highly infectious. When symptoms do actually show up, they often masquerade as a basic urinary tract infection, increased painful urination, or they might present as lower abdominal pain and excessive discharge. It really proves that the absence of symptoms absolutely does not mean the absence of an infectious disease. Moving on to our next stealthy threats, these classic memory aids highlight just how much overlap there is in symptoms. You've probably heard of the CLAP acronym for gonorrhea, and we use TRICH for trichomoniasis, which, by the way, is actually caused by a protozoan parasite. Both of these can trigger abnormal, thick discharge and pelvic cramping. In women, trichomoniasis can even cause the cervix to look bright red and irritated, kind of like a strawberry. Because the symptoms of these infections overlap so heavily and can often just be completely non-existent, it's a huge red flag that signals the need for immediate, comprehensive screening. You really can't just guess based on how you feel. So here's an absolutely crucial point. When we're dealing with these bacterial invaders during pregnancy, the rules of combat completely change. While a non-pregnant patient with chlamydia might just get a quick prescription for doxycycline, expectant mothers require highly specific alternative treatments like azithromycin. Why? Because standard antibiotics like doxycycline can actually cross the placenta and cause severe bone and tooth abnormalities in the developing baby. We definitely don't want that. Moving right along to part 2, the viral instigators, let's talk about the herpes simplex virus. We generally categorize this into 2 main types. HSV1 is traditionally associated with oral herpes, spreading through things like kissing or shared items like drinking cups. HSV2, on the other hand, is generally genital. But here's the truth. Both strains can actually infect either area through oral sex. Also, it's super important to note that active genital outbreaks at the time of labor are highly dangerous for an infant, generally requiring a C-section to protect the newborn from a devastating neurological infection. And this concept right here brilliantly illustrates why relying solely on visible source for safety is, quite frankly, a massive risk. With herpes, the virus can be actively shedding into bodily fluids even when the skin looks completely 100% normal. This is called asymptomatic viral shedding, and it's a primary reason why this virus is so incredibly successful at spreading quietly from person to person. Next up is HPV, the human papillomavirus. The wart mnemonic is fantastic for covering the visible signs, those rough, cauliflower-like growths usually caused by strains 6 and 11. But actually, those visible signs are the least of our worries. We really have to remember that strains 16 and 18 are invisible threats. They don't cause warts at all. Instead, they sneak in, alter cellular DNA, and are the leading culprits linked to cervical cancer. Now we're stepping it up in part 3, complex multi-stage threats. Syphilis is basically a master of disguise, operating in 4 distinct stages. It kicks off with a simple, painless ulcer in the primary stage, shifts to a full-body rash in the secondary stage, and then it practically disappears. Notice how the latent stage can last for years without any outward symptoms at all? This is incredibly dangerous for pregnant patients, who can unknowingly pass the bacterium directly to their fetus through the placenta, leading to congenital syphilis unless they're treated promptly with penicillin G. Decades later, untreated syphilis reemerges in the tertiary stage, absolutely destroying the heart, brain, and nervous system. Hepatitis B, on the other hand, makes a beeline straight for your liver. When this virus sets up shop, it causes massive inflammation and hepatomegaly, which just means an enlarged liver. Because the liver is compromised, it creates a sort of biological traffic jam. Bilirubin, which is a yellowish pigment created from the breakdown of old red blood cells, can no longer be processed into the digestive tract, so it backs up into the bloodstream, turning the skin and the whites of the eyes yellow and making the urine dark. Thankfully, this whole shebang is highly preventable through a multi-dose vaccine that we now start giving right at birth. Which brings us to Part 4, HIV, the immune hijacker. 37.7 million. That is a staggering number. It represents the global population living with HIV at the end of 2020. Since the beginning of the epidemic, tens of millions have lost their lives, really highlighting the massive scale of this ongoing public health battle and exactly why understanding how it works is so critical. Before we dive into how HIV attacks, we absolutely have to understand its primary target. HIV specifically hunts down cells with a CD4 receptor on their surface, primarily the helper T cell. Think of these specific white blood cells as the four-star generals of our adaptive immune system. They hold our immunological memory and release chemical signals to coordinate the body's entire defense. When HIV takes them out, the entire command structure of the immune system just collapses. So how exactly does it do it? Let's trace its life cycle. Think of HIV as pulling up to the CD4 cell, carrying a microscopic suitcase packed with its viral RNA and some very special enzymes. It attaches to the cell surface, fuses, and dumps that suitcase right inside. Then, using a sneaky enzyme called reverse transcriptase, it actually translates its own viral RNA into DNA. It sneaks that newly minted DNA into the host cell's nucleus, hacks the host's genetic code, and literally turns that crucial immune cell into a viral manufacturing factory. Eventually, the host cell dies as new viruses burst forth to continue the cycle. But here's a fact that usually blows people's minds. Despite how ruthless it is inside the body, a healthcare worker's chance of actually contracting HIV from an infected needle stick is incredibly low, just 0.23%. Why is that? Because the virus is actually remarkably weak outside of host fluids. It needs a direct, immediate route right into the bloodstream to survive and infect. So we've seen how these pathogens hide, how they hijack, and how they destroy. You might be wondering, with a virus this intelligent and bacteria this stealthy, how does modern medicine actually fight back? How do we prevent the devastating opportunistic infections that define AIDS, or stop cervical cancer before it even starts? That leads us perfectly into Part 5, screening and prevention. Let's look at the CDC guidelines for cervical health, which are highly specific. For patients 21 to 29, a Pap smear every 3 years is standard, mostly because younger immune systems can often clear HPV naturally. But for ages 30 to 65, we introduce co-testing. This means looking at both the cells and testing directly for the DNA of high-risk HPV strains every 5 years. This routine screening is, without a doubt, our absolute best defense against those invisible, cancer-causing strains of HPV. When it comes to HIV, we now have some genuinely incredible pharmacological shields. PrEP is a proactive daily defense taken by HIV-negative individuals before an exposure ever even happens. PEP, on the other hand, is pulling the emergency brake. It's a critical 28-day medication regimen that absolutely must be started within a 72-hour window following a potential exposure, like a needle stick or sexual assault, to stop the virus before it gets a chance to integrate into the cells. And science has totally revolutionized maternal care, too. For expectant parents, the takeaway here is incredibly empowering. If a mother has herpes, antivirals like acyclovir given late in pregnancy can suppress outbreaks. If she has syphilis, but happens to be allergic to penicillin, we can actually desensitize her to the drug to safely cure the infection. And if a newborn is exposed to hepatitis B, administering immunoglobulins and a vaccine within 12 hours of birth provides immediate protection. Engaging with the healthcare system allows for these targeted interventions that safely protect the next generation. I want to leave you with this one absolutely vital thought. As we've seen today, from chlamydia's silent spread all the way to HIV's microscopic hijacking, visual health is an illusion when dealing with these pathogens. The absence of symptoms does not mean the absence of disease. So you have to ask yourself, are you relying on what you can see or what you can screen? Take control, ask your doctor for the appropriate tests, and proactively protect your future. Thank you so much for joining me on this explainer, and keep learning.